I've had so many patients just like give me a hug, and they're like, I've seen so many people, and I've never actually felt listened to, that someone's looking at me like more than a sleep study, like more than, AHI in the sleep study, or more than this. It just feels like sort of a life mission for me of bridging those two worlds.
Welcome to the Be Well Baby podcast. I'm Dr. Emily Spaeth, founder of Be Well Baby in Portland, Oregon, and the Beyond Birth Blueprint, an online community where we support families through pregnancy, birth, postpartum, and especially life with a baby. This podcast exists because I believe families deserve better than what I am seeing in my work as a physical therapist, lactation consultant, and childbirth educator. Just a quick loving note before we dive in. Everything you hear on this podcast is for educational purposes only. It's not medical advice. Every body and every baby and every season is different, and you deserve support that is personalized to you. Let's get started. I'm so glad you're here. You know those conversations where you start in one place and you end up somewhere completely different and way better than you expected? Well, that's what happened at the very start of my conversation today. I sat down with Dr. Prashant Charugundla. He is a board-certified oral and maxillofacial surgeon and the founder of Summit Oral Surgery right here in Portland. We wanted to talk about tongue ties, palate development, and the airway, because I have seen so much of this in my practice. And we did talk about all of that. But what I didn't expect is how personal and vulnerable this conversation would become, because Prashant shared what it was that made him care about the work that he does. And when he told that story, I really felt it. So I'm so excited for you to hear it. Prashant really bridges Western surgical precision with a very holistic and unique philosophy. And unfortunately, it is unique in medicine. He really sees the face and mouth as not isolated structures, but the gateway to the body's entire system. Airway, sleep, and nervous system regulation is all connected, and he sees that. Prashant trained as a pediatric trauma surgeon, and he's been a professor at OHSU, so he brings serious clinical weight to everything that he says and that he's seen. And yet the way that he talks about his patients and what becomes possible when someone can finally breathe, it's not just a surgeon. It's someone who has seen the actual transformation and can't unsee it. I could tell you all the things we're going to talk about, but I just want you to listen to it. I learned so much in this conversation, and I know you will too. Let's welcome Dr. Prashant Charugundla. Prashant, thank you so much for being here today. I'm so happy to have you.
Yeah. Oh my God. Yeah. Honestly, I'm really honored, really grateful. I was telling you earlier that my wife had so many amazing things to say when we're at her mom's group thing. So I'm just really honored to be on your podcast. So thanks for having me.
Of course, of course. I'm really excited for people to hear what you have to say, because I think it's rare to actually hear from someone who does what you do. So why don't you first tell us exactly what your role is as a surgeon? Like, what are you looking at when you work with people, for the most part?
So my technical title or training is oral and maxillofacial surgery. So really anything above the clavicles up to the brain. I don't work on the brain at all, but from here up to here is how robust our training is. So it's really mainly structural in nature. And then from that, understanding how soft tissue changes are being affected by structure. And really, the scope of the training is really broad. And then when I got out into practice, I just slowly started whittling down my interests and things. And now I'm in a space where I really love working with structure and function as it relates to the jaws and the airway, and then understanding really the nuance of like why people are feeling the things that they feel, especially this like I'm sure we'll dive into some of the more nuanced and dismissed populations, but I really like that aspect of my practice.
Like the people who come to you who have been to 12 different providers and are like, no one is actually addressing my pain or my symptoms. That kind of person.
Yeah, absolutely. And I love that because I was that person a long time ago. So it just holds a really personal, sacred journey for me because I really struggled in my own life. And then it's funny, every time I get a patient that I share a similar story to, I just start on the inside, like welling up and I'm like, all right, I want to be vulnerable, but I also gotta hold it together here. There's a patient being like
Right.
me,
Well, there's no
right?
patient here, and I didn't know that we were going to talk about this, but can you tell me like what did you go through in your journey that kind of led you to be so compassionate and empathetic when you have that patient in front of you?
Yeah, I really, as a kid, even in middle school, I won't, yeah, I had this like really big string of constellation of symptoms as a kid too. I was 10, 11 with like terrible acid reflux, struggling with concentrating at school, even though I did excellent at school, but that was probably mainly my parents pushing me and saying, you got to get this done. And I really just felt fatigued all the time. And I had no reason to. I was really active. I played competitive tennis and I swam competitively, but I always had these underlying things. Like I was really anxious as a kid, but that was suppressed as well by sort of
Mm,
external cultural factors.
sure.
And it wasn't normal to be able to talk about those things.
Yes.
And I remember as I started to have a little bit more agency and autonomy with like how I wanted to direct my own care, maybe starting in high school, we'd seen multiple providers and I just kept getting like all these diagnoses. At one point, I'd seen a neurologist and he was like, you have narcolepsy. And then and then I was put on a stimulant and then multiple
Oh,
stimulants. It just like really didn't fit what I was going through. And then it was really not until I had seen more of an osteopathic doctor later on in my life. I was midway through college and I was really struggling here. And I've seen so many different providers, done a sleep study. I've seen an oral surgeon. I've seen an orthodontist. I actually saw a myofunctional therapist too. And that was one of the first people to help point me in the right direction.
oh,
So myofunctional therapy really holds a special place in my heart too.
totally.
I mean, I've known about myofunctional therapy for quite some time, but it was not until I saw an osteopathic doctor who was just like, hey, you've got like lots of nasal resistance, and I think you'd benefit from a septoplasty, and then referred me to an ENT. And then that was the start of like me really uncovering my own journey. But before that, I almost, I felt like I was going to give up. I felt like I was not going to ever reach the ambitious goals that I had for myself. And it just took,
I'm
yeah, pushing.
I'm sort of like, this is such an important story because you were so tired. People are kind of like diagnosing around whatever is going on. Did getting, what was it, a nasoplasty?
Yeah, I had two
Septoplasty.
septoplasties done. Yeah.
So did getting the septoplasty and maybe multiple septoplasties help with your fatigue just by
It
themselves,
did.
or were there other things?
It did significantly help, but myofunctional therapy was really huge in that journey. And I'm just in the second phase of me being like, okay, I know enough about how I treat my patients and I've seen enough data. It's time to like spend the time to work on myself a little bit. So I'm actually going to get a palatal expander myself. It was supposed to get done a few weeks ago, but I keep chickening out just because of timing. But I will eventually get one just to like kind of now that I know what the outcomes are, I think that's the last step in my own journey.
Gosh,
Yeah.
okay. Well, now that we've talked about everything, let's go back for
Yeah.
for our listeners and talk about what all of these things are for just a moment. So, myofunctional therapy, I think, is something in our world that we know about, but why don't you explain kind of the things that you were doing with your myofunctional therapist so that people can get a picture of what we're talking about?
I wish you probably have better language around this, and I don't want to butcher the profession, but the way that I see it and the way that I describe it to my patients when I'm referring them to a myofunctional therapist is usually I'll just say, hey, there's a specialist. They're like a physical therapist of like the face and the mouth and the neck, and they really help understand the compensations that have been created from long-standing structural abnormalities and muscle dysfunction, and they'll help deprogram some of those things so that you and I can really sit down and understand, okay, what other structural things are remaining. And I really work with them pre and post-op with even jaw surgery patients and TMJ patients that I know up front. The best way I can relate it to, which maybe resonates with you as a PT, is like,
Yeah.
I do think it's a specialized PT of like the myofacial complex.
Yeah, I would agree. I think that's a wonderful way to explain it. I think a lot of people will go into surgery thinking, oh, surgery is the answer. And it is so important to be looking at the whole picture. And I love how you approach surgery because as a surgeon, you're like, no, I can do something with the structure, but you have compensation patterns that you've been using for your entire life. So we have to address that as well.
Yeah, thanks for bringing that up. Yeah, that's a huge part of my philosophy, and that's like what I'm really trying to accomplish in my practice is exactly what you said. And also trying to educate other people on this is not for just personal benefit, but so that we can move away from this sort of, hey, there's a problem, let's just fix that one problem. It's
Yeah.
like, hey, we've got to look at the broader gradient and the broader spectrum of things that are happening, which this is why I love working with allied health professionals, because people like yourself, like you see the big picture so well. And I love that. Like, I love working with chiropractors and acupuncturists and physical therapists, myofunctional, you know, name it. But like people that really look at the broad picture, and it's like so nice and validating for me to work in that space.
Yeah, I
Uh,
think none of us can do everything, which some people will laugh when they hear me say that. But there's no one person that can be everything that you need. And so having a team of people who can work together is so valuable.
yeah, yeah.
Okay, let's get back to, what's really important to me in my practice is I work with so many families whose babies have tongue ties. And I'm curious, what is happening when a tongue tie. So, for example, I'm working with a patient who has a tongue tie, and then I look at the parents and I ask them to show me their tongues, and I'm like, well, we all have tongue ties in this room, you know. And so I'm curious, what is happening when a tongue tie goes unreleased in an infant? Because sometimes babies will just ride on the letdown and be able to compensate around their tongue tie. And I want to know, what are the downstream consequences? Because you treat adults, right? For the most part, exclusively?
I do treat a lot of adults, so I do see tons of the downstream effects, but I actually used to work for a pediatric hospital, so I have lots of experience with pediatric patients, but really my practice is 3 and above.
Yeah.
I don't work with, infants and like the early childhood.
Right.
Yeah.
So what are those downstream consequences that you might see in a 3-year-old or a 30-year-old when the tongue tie is not addressed and compensation patterns do happen?
I'd want to start with a 30-year-old because I think it's easier to grasp because you see a lot of the downstream structural effects that like are easier to digest. So a lot of what I see is upper airway resistance syndrome and sleep disordered breathing, postural compensations, breathing compensations, like voice tightness, like voice heightening, just like the larynx being heightened. Uh, and then
So
gait
interesting.
disturbances. Was I'm sorry?
That's so interesting. It wouldn't have even occurred to me that the larynx would be tightened and higher.
Yeah, yeah. So it is interesting. It is. Okay, I'll address that one first, then we'll go back to the
Sure.
30-year-old patient. But interestingly, the tongue, a lot of we're like in this now new landscape where a lot of people are looking at the tongue, including myself, and I get tons of those referrals. But the tongue is connected to, it's really the center point of being connected to so many different systems in the body. So I think we have to view it from that lens. And like one of the, like, I call it with my patients, the relay station. It's like there's a muscle at the back of the tongue, at the tongue base, which I know you're familiar with, but I'll just explain it for your audience. Is like the genioglossus muscle is really connected to the hyoid. And then the hyoid is like is pretty much the only bone in the body that is free floating, that's not connected to any other bone. And one of those things is muscle and ligaments, right? So when we have, and the way I compare that is like a tent and like a tent and bunch of tent poles. So you have one central tent pole and then like a bunch of other things that like just help pitch the tent and give you good projection and stuff. But you pull one tent pole the other way, like even an inch or 2 inches, it pulls on the entire system in an aberrant way, right? And imagine what that's doing in the body for years and decades for a lot of my adult patients. It like creates these nuanced physical changes, but they sort of created this avalanche effect for a lot of people later on down in life. So to answer your question, when we talk about voice, for example, the thyrohyoid is a muscle. If you want to talk about linear muscle relationships, the thyrohyoid is a muscle that goes from the hyoid to the thyroid cartilage, which affects the position of the larynx, right? So now you pull on the tongue, you heighten or you change the position of the the natural position of the tongue where it wants to rest. Now you're like dysregulating the entire hyoid bone, which has mass effects.
And then you also add in our propensity for being on screens and pushing our necks
Yes.
and, all of the rounded shoulders because of the backpacks. I mean, there's so much to the way that we not only compensate our posture because of structural differences in our bodies, but also the environmental things that we encounter throughout our lives.
Yeah, thanks for mentioning that. That's something that I like forget, or I like try to forget about it, is like it's natural for us to have our phones, and like we do need to be mindful of like some of these behavioral things that are impossible to eliminate in most people's lives. So like we have to look at it from I'm glad you brought in that, because sometimes I feel like recommendations are so black and white, and it's like, well, hold on, let's give these recommendations in a realistic fashion as
Yeah, we
well.
have to be realistic. We live in this world. We're here in the same city sitting at computers looking at each other.
Yeah. So you're so right about that. It's like, yeah, that's funny. Yeah.
Yeah.
Yeah, so to answer your question, a lot of what I realized in the last couple of years is every time I see an adult with a tongue tie, it's not a tongue tie patient. It's really a sleep disordered breathing patient. How many of those are actually sleep disordered breathing or temporomandibular joint dysfunction? I don't know yet. Yeah, just joint pain. We can dive into like the different types of joint pain and stuff like that and what people really mean when they say TMJ and like how I diagnose that and what's important to look out for. But really there's like a constellation of things that happen with tongue tie adults, and it's usually a narrow maxilla, which the maxilla is the floor of the nose right here. A lot of people think the maxilla or the upper jaw is just the tooth-bearing portions right here that you can see in the bone right above it. But it's really the entire, yeah, I think you saw a skull in your back table, but really goes up to the cheekbones.
Yellow
Perfect.
end.
You have a, yes. I love that your maxilla is also yellow. That's perfect. So notice how, yeah, it goes up to the cheekbone and then makes its way around the lateral aperture of the nose up to the forehead, right? Almost the start of the forehead. So
Yeah.
it's massive. It
And
is
inside the eye
inside the
socket.
eye. It makes up most of the orbital floor, which is showing, which is amazing, right? So it's a really pliable bone in adolescence, but then in you and I, Emily, that's like completely fused right now. It's one giant bone. Before it used to be two separate bones that can move like all the way from, bottom to top where you showed.
And
So
that's one of the reasons that craniosacral is actually more effective on a baby, I think, than it is on an adult.
I agree with you. Yeah. I agree. And I love that you're doing this like early intervention, because as much as I love surgery, there's plenty of patients that I can like work with and operate on. But I think the more that we can prevent these things from happening, just the better for like everyone, our world in general, and like these kids that don't need surgery eventually. That's like a fantastic thing to be able to achieve.
Yeah. And I mean,
Yeah.
thank goodness we have it when we need it. But what if we didn't need it as much?
Exactly. Exactly.
Yeah.
Yeah, I mean, yeah, we can probably have a whole conversation about that. But anyway, yeah,
So what about the 3-year-old? Are you
uh,
already seeing those compensation patterns even as young as 3?
absolutely. It definitely. So that's an interesting one. I think the 3-year-olds, we have to talk about not only structure, but like autonomic nervous system and like nervous system changes that happen with like a tongue tie that's not adequately worked around, like having compensations. But definitely from a structural perspective, you can start to see a few things like a little bit of a V-shaped palate that's developing. It's narrow. Mouth breathing is really common that I would pay attention to. That can be in a 3-year-old due to tonsils, adenoids, other structural things as well. But I think you have to rule out like, okay, why is the mouth breathing going on? Is it because of a lack of lip seal and the tongue posture not being adequate? Or is there like tonsils and adenoids getting in the way and the mouth breathing is the compensation? I think we have to think about why is the compensation happening. So you can see some of these things in a 3-year-old, not only from a developmental structural standpoint, the bones themselves, but sort of the downstream effect with things like mouth breathing, even ADHD. That's, I think if you want my personal opinion on that, maybe sometimes overdiagnosed without looking at like why it's happening.
Sure. And also, I think, people aren't really considering how mouth breathing throughout the night is impacting sleep. And if you have a chronically sleep deprived child, then they aren't able to focus on whatever they're supposed to be focused on. They aren't able to self-regulate as well. And let's talk about the autonomic nervous system in there for a second, because I think I have a whole episode on like, what's the nervous system? Because we talk about it a lot, just throw it around in medical conversations.
Yeah.
So people can go listen to that if they want, but let's just briefly talk about what you mean when you say the autonomic nervous system and how that would impact a child. And then I want to talk about my own children, just selfishly.
Yeah. Yeah, let's do it. I love that. It's always nice to just bring in a personal aspect to this because we're all going through it. We're all in it together. Okay, let's see. So autonomic nervous system, especially, your question was directed more at children, right? It's applicable to adults too, but really when the tongue, let's talk about mouth breathing and tongue posture first. When you're having mouth breathing and the tongue's not up on the roof of the mouth and you don't have good lip seal, you're missing out on a few really important things with just pure nasal airway. There's nitric oxide that gets released in the paranasal sinuses during nasal breathing that actually dilates. So it opens up blood vessels. It opens up the airway on a microscopic level. And it's really important. And I think it's dismissed because people think it's like it doesn't have enough of an effect, but the body, it feels everything, right?
Yeah.
And these little things add up.
Compounding over time.
They're compounding. Yeah, I like that word, compounding. So that, and then when you're mouth breathing and you don't have the proper lip seal, you don't have good tongue posture, you're not nasal breathing at night. So we're missing out on this like bronchodilation or vasodilation that's happening. The body also perceives this as sleep disordered breathing. We fall into this category where maybe the mouth is open, the lower jaw falls back a little bit, the hyoid falls back, and we start to constrict the airway a little bit. And what does this do? We have good data from Stanford from the 80s, actually. It's like not even new science that shows that if that's happening, we go into this, it's a combination of parasympathetic overdrive when we are not breathing, and then also a sympathetic overdrive. So it depends on like when you are sleeping and when these obstructions are happening and how they operate in physiology. But essentially, like the way I'll describe it to patients is like the body is going into this stress state overnight and it is dumping a lot of cortisol and norepinephrine, which actually causes, we were talking about vasodilation, norepinephrine does the opposite in the body. It starts to constrict things and it heightens things. And so it makes sense that like if you're trying to sleep for 8 hours and you're having this sympathetic overdrive overall, that you're essentially in this fight or flight mode when you wake up. And it's hard to recover from that because really nighttime is when we should be recovering. So
Yes,
a 3-year-old feels that too.
Yeah, all of our inflammation should go down overnight. It should be a time where we can truly rest.
I just wanted to pop in here and say that if the Be Well Baby podcast has helped you in any way, if our team has helped you in any way, the people who find us because they heard about us from a friend, because they heard about us from a midwife or a doula or their pediatrician or their OB. And we value those connections so much. And we know that the only way for people to find excellent healthcare is for people to talk about it. So if you have a minute, please leave the podcast a review. It will help people find this podcast If we band together and shout this from the rooftops, then we will be able to change healthcare. Thanks.
So I just want to make sure I got this right. There's supposed to be nitrous oxide released when we nose breathe.
Yeah.
And when that happens, it causes vasodilation, which means blood vessels get to dilate and get bigger, so more blood can go everywhere it needs to go in the body for bringing all of the good nutrients everywhere and healing and all of the things. If the nitrous oxide does not happen because we're mouth breathing, then you get vasoconstriction because you get increased cortisol levels, which is a stress hormone. Is that right?
Yes, you got the whole picture right, but I think it's the lack of dilation plus the increase in sympathetic drive, which causes that. It's like norepinephrine. So it's adrenaline. You're having adrenaline not being able to be offset by the vasodilation from nitric oxide. So you now have two things that are against you with causing constriction.
Got it.
And I thanks for saying that the blood's so important for vitality and for taking things to different parts of our body.
Yeah, absolutely. Okay, awesome. I think we have like a really solid understanding of all of that. Now let's talk about how my children, and if you're watching on YouTube, you can see me talk about that skull and show the maxilla on the skull and also what I'm about to do, which is going to be silly. But my children would breathe like this when they slept at night. So they're open mouth breathing, their jaw is recessed, and they're clearing their airway basically to be able to breathe appropriately enough to sleep. And I, of course, knowing what I know, was like, this is not right. And they would snore. And the first one got a sleep study and she passed. There was just nothing wrong in the sleep study. Can we talk about that? Because ultimately she did have a surgery and I'll talk about it. But what do you tell people who are like, well, the sleep study said there's nothing wrong?
I'm so glad you brought that up because this also falls into this category that I'm really passionate about of like missed diagnoses. So a sleep study, and it depends on if you're doing it in-house or like in a lab in a sleep. So there's two ways to do a sleep study. One is at home and one is in a lab itself, like a sleep center.
I'll tell you, she did it in a lab, but it was at a hotel.
Yeah, at a hotel, with a sleep tech, And so she had more monitors hooked up on her. So the thing that's happening is like there's a whole gradient of sleep apnea. So essentially how many times your body is collapsing on the airway. There's very strict criteria based on not only old diagnostic criteria, but insurance criteria. You have to stop breathing for a certain amount of time, X number of times per hour. And if you don't fit that strict criteria, then the sleep study says, oh, you don't have sleep apnea, or you don't have a sleep problem. And of course, a sleep medicine doctor is great at looking at different things like fragmentation and sleep plateaus, nasal pressures and things like that. But what I would say to you directly and to other patients that I've had with this is like, don't feel discouraged by a sleep study that does not show that the symptoms that you're feeling, they're real symptoms, but likely you fall into this upper airway resistance syndrome category that is your sleep disturbances are caused by respiratory effort rather than like cessation of breathing completely. So it's your body, we were talking about just like the overdrive of the system. It's essentially your body's way of staying awake so that you can breathe.
And stay alive.
And you can stay alive. Yeah. Does that answer your question?
Yeah, I think so.
Okay.
I also think about those sleep studies as whether or not you have it done at home or in a lab, you are taking one night of data. And in a lab situation, my daughter never sleeps on a queen size bed in a hotel room next to her dad all night. You know, it's just a different way to sleep, and falling asleep is harder, and they actually ask you to stay up really late so you sleep harder when you finally fall asleep, or you don't because your cortisol levels are too high and you actually can't fall into a deeper sleep. So it is one snapshot of one night. And that's what I took from it, that I was like, no, these symptoms are so real. I had my tonsils removed when I was 8. My husband had his removed when he was 5 because he wasn't eating anymore. Like both of us, she just came by it naturally. We knew that she would have some airway stuff. So when we ultimately did have her tonsils and adenoids removed, and it did make a difference. She sleeps with her lips closed. And the same thing with my son, and probably the same thing with my daughter, although we did get her tongue tie released earlier than the other two. The other two had their tongue ties released when they had their tonsils and adenoids removed.
At the same time. Okay.
Yeah,
Okay.
so they were already living with compensation patterns that my youngest got her tongue tie released when she was only 6 weeks or 5 weeks old.
Yeah.
So she doesn't have as many compensations, but she probably does still have some. So is there anything else we need to talk about that? You know, airway, tonsils, sleep study. We went a little off track.
No, I appreciate you bringing in more context. I think there's definitely things to unpack in the story with your kids, like the youngest one. Compensation's definitely so you got a tongue tie released when she was 6 weeks old. That's great timing. And I think when I would look at her, I would say, okay, great that we got the tonsils, adenoids, and we got some structural things out of the way. We really want to remove any interferences with the normal physiology, neutral positioning, which is funny to me saying this to a PT. Yeah, this is your bread and butter, but we really want
It's
to
hard to
remove.
treat your own children.
Yeah, I agree. We actually, it's funny. My daughter needed a tongue tie release, and I was like, no way in hell I'm doing it. Not doing it. Yeah.
Totally.
But it was. I think you removed some of the structural things, and you allowed biology to kind of make its way. How old is she now?
She's 7, and she also, in the past couple of years, has gotten a palatal expander, which was magic, and now wears a retainer to keep that in place, and probably will end up with future orthodontia. I, had braces for my whole life, essentially. So my daughter, in losing her first teeth, had shark teeth. So she had 2 sets of teeth, basically, because the way that the structure of her mouth was working, her grown-up teeth were not pushing out her baby teeth. And it was because everything is so crowded in there. And when we were able to get the palatal expansion for her, her teeth started being in better alignment as they came in. My son had palatal expansion younger than she did because they had them at the same time, because we wanted to see if the palatal expansion would affect his airway enough so that he wouldn't need the tonsillectomy and adenoidectomy. But what happened was he has now, like years before she ever lost teeth, started losing his teeth because his grown-up teeth are actually pushing on the baby teeth where they're supposed to, which is watching the structure of that is so cool and so fascinating. And ultimately he did get the tonsillectomy, but I was happy to be able to do something a little less invasive first, just to see.
I am actually a big believer in doing it the way that you did it. I think structure should change first and then soft tissue. So bone, if we move bone first and we make the room bigger, then we can always go back and remove furniture. But if we start removing furniture first and then we try to expand the room, maybe we've done too much that we didn't need to. And it's also nice to improve the structure first and then be able to say to a patient, okay, let's work on some soft tissue stuff that will be icing on the cake for you. And they really notice a difference between those things. And I like the way that you did that.
Yeah, cool. Approval from Prashant. So I'd love to know from your perspective, is there a good window to do this procedure if we're thinking about doing a tongue tie on an infant? So many families are like, I don't want to hurt my sweet baby, And so is there a window of opportunity that actually leads to better outcomes if we do it sooner?
I also want to unpack the nuance of tongue tie releases and how different they are, like a frenuloplasty versus a frenectomy. And I want to get into that, but the really good window of opportunity is early, like you did it on your youngest at like 6 weeks old, 4 weeks, 8 weeks, something like that. The therapy is barbaric afterwards because a child that age cannot participate in post-op therapy, right? So as parents, we're literally putting our fingers in there with some coconut oil or vitamin E oil, and we're stretching out that tissue so it doesn't contract again. But there's going to be some contracture because we can't do it. It's impossible. Like imagine I mean, I know you don't have to imagine it, and I don't have to imagine it because my wife and I went through this, but it's so hard to see a crying baby and like you are doing something to cause that pain, and it makes you not want to keep going, even though you need to, it's just like for the greater good here. So it's this delicate balance, and we're never going to do a perfect job. And then my point being is like early intervention is good, but I think the critical window to start doing post-op myofunctional therapy and get a reassessment is like ages 3 to 5, because I think that's when kids can participate in things like myofunctional therapy and start to do floor of the mouth exercises and tongue exercises. At that point, you've like really looked early enough and said, okay, can we prevent a bigger frenuloplasty from happening, which I'll get into next, or structural abnormalities from developing early on. But I think once you start to get into the 6, 7, 8, 9, then you've already started to develop lots of compensations with fascia and muscle, and it becomes more difficult. But these are not binary things. Every patient's different, and this thing operates on a huge gradient. So that's the thing I'd like to impart on people is like, if you don't do anything until your kid's 12, it's not the end of the world. It's never too late. It's just like there's different solutions for things at different times.
Let's dive into the difference between these two procedures that you're talking about.
Okay, so in an infant, it's oftentimes we just do a frenectomy, which a lot of people think of when they think of a tongue tie release in layman's terms. It's just, take a pair of scissors and you clip that cord that rests between the tongue and the floor of the mouth, right?
And sometimes with a laser.
Most of the times with a laser nowadays, because it is so unsafe and really difficult to do it effectively, we're worried, as surgeons, we're always worried about bleeding, especially on a young child like that. Even a tiny bit of blood loss can cause a big, big problem and create an unsafe thing. Also, you're working on a moving target. You're not going to put a 6-week-old under general anesthesia for a basic tongue tie release unless there's a failure to thrive, which you would know at the hospital, right? If there's like an absolute failure to thrive. But in my adult patients, or even like patients that start to approach like 7, 8, 9, 10, what I'll do more of is a functional frenuloplasty. So I really want to address the fascia behind the initial cord that you see. And the way I describe this to my patients is like I imagine a tongue tie to be like a sailboat where you have like 3 different anchors that go into the ocean. Like the one that you can see, the cord in front is the one that's commonly clipped here. And then behind that is fascia. And then behind that is muscle. And then that muscle that I'm referencing is anterior genioglossus. And that's the one that we talked about briefly earlier. So in a functional frenuloplasty, you really want to address like, where are people actually being tethered? Is it purely in the front there? Is it in the middle? Is it in the back? And you have to address those things in a functional way and like make sure you get those and work closely with the myofunctional therapist to address it.
Yeah, as we're talking, I'm like moving my tongue around. So a frenectomy is just clipping the front of that tissue. It's usually relatively thin. In some patients, it's thicker, but a frenuloplasty is actually getting into the fascia behind that and the muscle sometimes. Sometimes, all the time?
Not all the time, just depends. Yeah. And there's different ways of doing frenuloplasties. Historically, I've done what's called a Z-plasty, where I literally reorient the tissues. And that's a technique I still use on young children that I can't really keep awake during the procedure and we've got to put them to sleep. I still do that because post-op therapy, I don't want to rely on a 3-year-old or a 5-year-old to be able to do post-op therapy, especially after surgery. It's so hard. And so I think I have to do my job as a surgeon to lengthen the body of the tongue. So there's different techniques depending on the type of situation you're in.
So a Z-plasty sounds like potentially, I mean, I'm guessing it's a zigzag. And it sounds like it doesn't require as much follow-up in terms of doing the exercises because you're not just cutting straight across and then asking that wound to heal in a diamond shape. You are actually sewing it back together how you want it to heal. Is that right?
Gosh, you're so good at taking what I'm saying and like framing it in a way that, yes, you're absolutely right. It is essentially like reorienting. It's a technique borrowed from plastic surgery with old scar contractures, but I'll use it oftentimes with labial tongue ties, lip ties and tongue ties, where you're physically reorienting tissue so that you can get it to heal without the necessity of post-op therapy.
Wow.
Therapy is still necessary because I can reorient the front anchor there really well, but I cannot do that same type of technique with fascia and with muscle. So just because I did this part doesn't mean that, but it at least reduces the pressure on the burden of needing immediate post-op therapy.
Yeah, that's huge. That's huge.
Yeah.
So when you are talking about an anterior tongue tie versus a posterior tongue tie, is that kind of the difference between those two procedures?
Yep. Yeah, you'll hear those, and some people will throw around mid-tongue tie as well. So essentially, like the same concept is like find the area of restriction and get it while keeping anatomy in mind.
Yeah. If your baby ever needs a pacifier, and not all babies do, the one that I would want in your world is the Ninny. It's the only pacifier designed to actually mimic the shape and function of the breast. It looks like this. It's very soft here, like an areola, and then harder, like a nipple. And this shape means that it supports healthy oral development instead of interfering with it. I really love it because babies don't just passively hold it in their mouth like the ones with a bulb on the end. They have to actively suck. It's hard work. It's my workout pacifier. And that matters for feeding, for regulation, and for long-term oral function. It's especially beautiful for breastfed babies who need a little extra soothing without confusion. If you're listening and you're pregnant, postpartum, or buying for someone you love, you can grab a Ninny through the link in the show notes or use the code BeWellBaby for 10% off at checkout. It's one of these tiny little tools that makes a huge difference. And my favorite part about it is that babies don't get dependent on it. All right, let's get back to the show. Would you say that most people are not trained to do a true frenuloplasty?
It's good. It's a good question, and I don't know enough, but I will just say that I think it is important to ask the right questions when you're going to a provider and find out what their technique is and why they're doing it when you're picking someone. Hopefully that's helpful in answering your question. Yeah.
I think so.
But I think there's a wide, just like with any procedure, there's like a wide variety of experience and technique and also familiarity with post-op complication and downstream effects. Like, I think this is the other area where we have to be careful with tongues. And I understand why pediatricians historically and currently are still like a little bit hesitant about the overdiagnosis, which I don't think they're being overdiagnosed right now. But when we are not evaluating them in the context of the downstream effects or structural things, they can feel like we're just doing surgery for no reason. And so I think that's where we have to find. I think just if you ask the right questions, you'll figure out, is this the right person to do the tongue tie release?
Yeah. Let's talk about that because tongue tie is so controversial, right? I mean, we're talking about it because this is what we deal with every day, but some people won't touch the topic at all. And I would love to talk about, like, first, what do you think is happening in terms of our society and our understanding of the airway that is leading to diagnosis of more tongue ties, which you just said you don't believe is an overdiagnosis. So what is it? What's happening?
I think historically I think surgeons got really cut happy and we pissed off pediatricians and probably midwives, which midwives are, I think, less resistant to tongue tie releases from my experience. But I think pediatricians are so protective because they see these kids for such a long time. They're so protective over like the outcomes that are happening. And I think there's probably a few complications that happened historically that sort of soiled the diagnosis of them and the openness to them. And I say this also from personal experience. My daughter is really obvious to us needed a tongue tie release, and our pediatrician pediatrician who is amazing, like really cares and is like so great with our daughter. We love her. We would never go to anyone else. But she did not know that I knew what I knew. I just kind of like, I don't tell that to people when I go in for a doctor's appointment or anything. But we said, hey, like Safi's having trouble. Like she's vomiting a lot. She seems like she's swallowing air. She's clicking. She's unlatching frequently. And who's the really important pivotal in our education was a lactation consultant, which was really funny. Like even given my experience with this stuff, but a lactation consultant was so important with validating the experience. But anyway, I'll cut to the chase. As our pediatrician was like, there's no tongue tie. Like, you don't need to get that addressed. And I didn't listen. We went and had someone do the tongue tie released. And immediately that same day, all those symptoms that we were seeing, all those signs that we were seeing of a tongue tie went away within one day. It was amazing. So to answer your question, I think there is hesitancy around cut happy surgeons who are not looking at like really, okay, is it necessary? And like how necessary is it? And then we also operate oftentimes in Western medicine in these binary things. Is there failure to thrive or not in infants? If there's failure to thrive, let's cut it. If it's not, leave it alone. It's like there's such a gradient in between, and I think we have to live there in reality.
Yeah, I think too, there's, some babies are more prone to an oral aversion. And if we then do a tongue tie release, they might be like, no thanks, nothing else in my mouth, please. And we have to figure that out first. And sometimes, I'd love for you to talk about in your experience what you were seeing with Safi, because what is true is that there are so many stories like yours where people go in, they get the release, and the baby immediately latches for 15 minutes and they've only latched for 5 in their whole breastfeeding journey. But that also doesn't always happen. And it's sometimes a slow roll, and all of the compensations that they've had, growing for 9 months inside of you and for the past few weeks of life and sucking, that's all they do, right? So they already have compensation patterns so early, and sometimes it doesn't happen like that and it takes time. So what were you seeing in Safi before you had the release? Like, what were those symptoms that you talked about that went away immediately?
Throwing up constantly, like after every meal, just vomiting everything right away. We could hear clicking as she was latching and trying to feed. Lots of clicking and unclicking, and just latching and unlatching. Those are the two big things that we saw. It was really difficult for my wife to nurse.
Yeah, totally. I'm thinking currently about a patient that I have who is so unhappy, and with my assessment, I'm not really sure that he has a tongue tie. In fact, like maybe he doesn't. Are there other things that can be happening for babies that are not related to the tongue that will lead to them unlatching and latching and taking in air and having digestive issues and things like that are not tongue tie related, but maybe structurally related?
So I think that's hard there's such a like genetic through line there, and then there's epigenetics, and it's so hard for the epigenetics for us to understand what's happening. Possibly, to be honest, I don't know enough about the the infants that are coming out to say like, okay, there's structural abnormalities that could be causing that early. My first instinct goes to like a potential neurological issue and sleep disorder breathing. I think a lot of infants that have this type of behavior, like even acid reflux, it can be related to sleep disordered breathing. And the other theory that I have on this is, how's the milk supply looking? Like that's the other question I have, which can be related to a multitude of things, one being the sleep fragmentation that happens during the pregnancy phase and the postpartum phase, right? Whether you have a structural abnormality or not, there's lots of things that happen in that phase. So it's like, I don't know. I think it's a chicken or egg question. And to answer your question directly, I don't know enough to be able to give you a good answer.
Yeah, I wonder sometimes, if you had, I know you don't see infants per se, but if you had someone who had a release and did all the things and, the stretching and all of the things that she needed to do postpartum, and now the tongue seems to be functioning relatively well, but the baby is not sleeping and they're, getting 20-minute stretches of sleep and they're fussy all the time. And if I had to guess, you'd say sleep disordered breathing. So then what? Like, where do they go from there?
So there can be like sometimes syndromic. And are you talking a subset of patients that may be like a little bit syndromic or have like jaw abnormalities, or do they look okay?
Well,
So
maybe I have a specific patient I'm thinking of who does have a recessed jaw, like maybe even a little micronanthia, but no genetic diagnosis.
So that's huge. That needs to be evaluated like ASAP, in my opinion, because this is a good time to start to do like some pediatric distraction osteogenesis where you can actually help the lower jaw grow forward by like using a little crank device. It is surgery.
Really amazing.
It is amazing. Yeah, it's cool. Yeah. I can't imagine what that would feel like to go through as a parent, but from an outcomes level, it has beautiful outcomes, and I think it does really help. But I think those are things to look at is if you have a recessed jaw, even if it doesn't fall into this category of someone looks and you're like, oh, wow, there's like no lower jaw. Even if it's like, I don't know, let's just use arbitrary terms, half of a normal jaw, that's going to have huge effects on like the ability to even get the lips together, right? Which is going to have an impact on sleep and the ability to like achieve good suction.
And so you're looking then for an ENT referral who sees infants.
Good question. I would look for a craniofacial surgeon, so a fellowship trained craniofacial surgeon, which can be usually plastics or oral and maxillofacial surgery, and there are some ENTs that go and do that fellowship as well. But typically, especially in the Portland metro area, that space is dominated by plastic surgeons. Yeah.
Cool. So something that I hear about a lot, especially postpartum, but also during pregnancy, is people feeling like they wake up kind of unrefreshed and they are just told, you're pregnant. Of course you're tired. And then a lot of postpartum patients are really like, you have a newborn. Of course you're tired. But I mean, and I know that I did this crazy thing when I was pregnant where I went, when I was sleeping and it would freak out my husband. So what's happening to a pregnant body? And when you're postpartum, like what is going on with the airway that makes a difference in your sleep?
Yeah, good question. So before I even dive in, did all that stuff resolve for you after delivery? Okay. So I think of pregnant and postpartum patients in like a few different categories. One, someone must have had like a little bit of sleep disordered breathing beforehand, and then the pregnancy and the changes with physiology and structure like amplified those things and made them really apparent.
Oh, that is
And then
so true for everything. Every pregnant person that I see as a physical therapist who's like, oh, well, I always had this little pain in my low back, but now it's really bad. Pregnancy just amplifies all of the things that your body is trying to tell you.
And it's interesting that it like probably informs us of compensations that have been happening that now we're like, oh, this is real. I've got to address it.
Yeah.
And I like that. It's interesting. I think the baby is just like the timing of these situations and not really the thing that triggers it. It's like the timing of awareness more than the trigger itself. But really what's happening from a structural perspective, I think in a physiological perspective, that's important when we talk about sleep disordered breathing. One, we have tissue laxity that happens, which is normal because we want to prepare for delivery, right? A big baby needs to come out of a small space. And how do we do that? We have to start to open things up, widen things up. So we have good data to show that our collagen levels change. So collagen type 3 increases, which is increasing tissue laxity and widens things up. We also have fibrillin that helps relax things and elastin. So, and those are caused by like hormonal changes, right? Changes in estrogen, progesterone, and relaxin. Relaxin is one that not a lot of people talk about. It's just such a funny name. It's like relaxin. Yeah, it's relaxing things.
Relaxing
It's really
everything.
exactly. I'd love some relaxin in my daily life, but
Sounds like a drug.
yeah, maybe we should battle it out.
We
Yeah.
should.
I think together we will. Like I think we'll form a little circle to helping people like relax with like our therapies and our modalities too.
That'll be our
But
new practice name.
Relaxed. That would be such a cool multidisciplinary clinic. Yeah. So what's really happening is like the way that I described the airway is like we need air to go from the nose and the mouth into like the back of our throats into our lungs, right? There's just like one big straw and we have different inlets and outlets to it. Even one little collapse of that can clamp off. There's an effect called Bernoulli's and like it just like even one little area that collapses amplifies the effect, the negative effect. Okay. So when we are talking about the airway and tissue laxity and stuff, where do we want to sleep when we're just normally sleeping? Either on our side or our back is usually where most people sleep, unless they have real bad sleep apnea. Then we have stomach sleepers that usually prefer that. But in pregnancy, when you have this tissue laxity already are starting to relax things and you overlay that on top of a structural abnormality, now you've introduced two things on top of like it's just throwing salt in the wound and you're collapsing the airway a little bit. And then you have weight gain changes, right, that are inevitable that we want, right? And then we also have the diaphragm really comes up because of where the baby is sitting.
And it can't descend like it's supposed to.
We can't descend, exactly. And then we introduce a third thing, which is nasal airway resistance. We have strong data to show that it is common for rhinitis and congestion, nasal congestion to come up during pregnancy and even put in the postpartum phase. So those three factors, I think, really produce a lot of sleep disordered breathing symptoms for a lot of people. And it depends. Does it resolve like in your situation? Do you, like you probably didn't have a big structural abnormality or none, and then it resolved postpartum. And then in a lot of patients, I'll say don't feel discouraged because I think pregnancy was not the cause of it. You had it beforehand, but pregnancy showed you. And then afterwards is like, okay, if it gets better and you feel like you're compensating enough and you feel like you're at a good baseline, don't do anything. But then if you realize, okay, this is important for my life and I want a quality of life change, that's when you should go get, evaluated for some sort of sleep disordered breathing that has a structural etiology.
Yeah, and I am lucky enough that I don't have tonsils or adenoids, but I'm sure that if I did, it would not have resolved because that structure, and I have a tongue tie, I had it released, but I know that those structural things were impacting everything. So I think that, that is so important for people to hear. I had two people on my Beyond Birth call this week say, oh yeah, I woke up in the sort of like gasping for air moment just this week. And it's so cool to be able to tell them here's why. And there's something that can be done about it. Would you say that people should do something during pregnancy?
That's a good question. I've thought about that so many times. And I thought about the first time I had a pregnant patient in her first trimester who was like, I don't want to wait. I know the risks of surgery. And I was like, okay, we have to find a balance here. Like we can do some things to help guide you. But there's a nuance. There are some things that you should do during pregnancy, like you can do a tongue tie release if it's really creating a structural problem. But I wouldn't do any skeletal surgeries because I think you open up yourself to a can of worms with introducing harm to your baby with anesthesia and things. But there's a nuance to this, right? Is like if we don't take care of it during pregnancy, during the formative years of fetal development, and the mom is struggling, are we doing the baby and the mom any good? So I think the response to your question is like, I think it does depend on the client or the patient itself, and also a conversation with the OB, because if, as long as there's a nuanced, open discussion with everyone and everyone knows the risks of certain things, I think there is a little bit of room to do certain things during pregnancy.
Cool. That's so good to know.
Yeah.
Okay. To wrap this up, I know that you really bridge this kind of Western surgical precision and your experience. You have so much experience with a much more holistic philosophy and really looking at the structure and systemic health. So how is that lens a little bit different than your average ENT surgeon?
Thanks for asking. So I think the thing to start, I'll just give you a little anecdote from when I was a kid. I was born and raised here to like immigrant Indian parents, and even as a kid, I identify with being Indian like so much. Like I don't even identify really even as a kid as being American. It's just like the culture that I grew up in really strong. But even then I was so dismissive of like Indian, old school Indian medicine, Ayurvedic medicine. I remember even as a kid, I'd be like, oh, those are, sugar pills that we're throwing at a problem. And I was like, now looking back, I'm like, wow, that's the power of like Westernness and the Western medicine influence is like, I was, even as a young child with no cognitive function to understand what was going on, I was like, I'm going to dismiss this thing that I identify with and thousands of years of medicine that have happened and just believe in this one thing to fit probably a subconscious cultural norm, right?
It's very,
Yeah.
very strong.
So looking back and just thinking like, wow, I've just gone through so many shifts in my own personal journey. And I think it's really shaped also the way that health was approached in my own life. And like for me personally, I'm like, wow, I wish someone just took a step back and looked at all the constellation of symptoms that were happening. And so really my focus right now is like, I am so grateful for all of the precise surgical training and the robustness of the surgical training that I've received with like moving bones and soft tissue. It's like really fun for me and I really love it. But also I think the artistry and like the fun, the real like pleasure and fulfillment that I'm getting is really just looking at things from a macro scale and understanding, okay, what does a lactation consultant do? What does a myofunctional therapist do? What does a PT, a chiropractor, how do all these systems work together? And I love being the person that is able to just say like, okay, this is what I see from a broad overview. And these are the people that like, let's piece this together for you and let me like sort of help guide you in the right direction. And then we just work together collaboratively. And I can't tell you, I thought that was just selfishly going to be meaningful for me, but I have had so many patients just like give me a hug and they're like, I've seen so many people and I've never actually felt listened to, that someone's looking at me like more than a sleep study, like more than my, AHI in the sleep study or more than this. It just feels like sort of a life mission for me of bridging those two worlds. And I think the Eastern medicine is not, I don't do any like Ayurvedic medicine or holistic medicine, but I think it's the lens of understanding that people are humans with like multitude of experiences and having curiosity around what those experiences have led to and like how they've produced not only physical symptoms, like mental, somatic symptoms, spiritual, like outcomes, like all those things. I think they make up a person. It's not just, I think we've gotten too used to just being like, oh, there's acid reflux. Let's throw Prilosec at it. It's like, why is the acid reflux there to begin with in this particular person? Like, and I think that's where I come from. And I really like that.
That's amazing. I mean, just hearing you say that, that is how medicine should be. That's what it's supposed to be. And the fact that what you're talking about it's very unique. Like that is very unique. And that fact is both very sad, but also brings me so much hope that there are so many medical providers like you out there who are trying. And I think that anyone who hears this conversation and knows that it's possible to go to a surgeon who actually sees you as the full complex human that you are is possible, like that is a huge gift. So thank you so much, Prashant.
Thanks for saying that. Yeah, it's validating for me too. I just like really, yeah. So thanks for summarizing it that way.
You're welcome. And thank you again so, so much for your time today. I'm so grateful. And I know that so many people are going to benefit from this conversation across the world.
Thanks, Emily. Appreciate it.
Of course. To wrap this up, I'm just going to say, gosh, if I ever need surgery, I want Prashant to do it. And I really want that to be the standard in medical care. I want the standard to be seeing a whole person's experience, the standard to be looking until we find the answer. I'm so grateful that Prashant exists and that we have people like this out there that we can refer to when it's necessary. So if you are feeling fatigued and you haven't actually looked into why, there are so many good reasons that could be happening unrelated to the fact that you might be getting woken up by a baby. Thank you again so much for being here today. Thank you, Prashant, for your time. And I can't wait to see you all next week.
Audio and music production by the amazing Peter Gary, with Lillian Ewert managing all scheduling and operations of Be Well Baby, including this podcast. Thank you both for making this happen. New episodes drop every Wednesday, and I'd love for you to follow us on Instagram at BeWellBabyPDX or visit BeWellBaby.org to book a time to chat with us. And if this episode helped you, please send it to someone who's pregnant, postpartum, or someone in your life who wants to support you better. No one should have to do this alone. Welcome to Be Well Baby. You're in the right place.